There we go.
Professor D'Onofrio, are these like the wording of these questions like similar to ones that we'll probably see on the state board, or is it like this is like simplified?
Nah, this is similar to what you would see on the state board. That's part of the reason why I like to do this type of stuff.
Okay, cool.
Yes. Did you guys do a Super Bowl box?
No. You?
No.
What do you got? Who do you got?
You know what? I gotta say, I can't tell you how many years I hated the guy. I can honestly say I'm rooting for Tom Brady.
I like seeing the veterans take it down.
So, I think I hated Belichick more than Brady. So now that Brady's where he's at, I really wanted to stick it to Belichick.
Well, in many ways, he already has. What, they go 6-10?
Yeah, no, you're right. So,
no. And for years it's like, oh, he's only good because he's with Belichick and he's on this great team. One blah 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 blah.
Yes.
Okay. He just made it to a Super Bowl again with a brand new team. So.
Yep, that's how I'm feeling.
The Brady Peyton debate will never end.
Anybody doing any bad gatherings, any parties?
I mean, Dr. Fauci says we shouldn't.
He also says we should wear 2 masks. Are you doing that?
Actually, I'm wearing 6 masks in my sleep, so because hoping it doesn't sneak up on me.
Yeah.
I think
COVID
that's
might
your.
come rob your house.
I think your wife is adding more masks, hoping that maybe you get like a poxic or something.
Well, luckily, she was just walking by as she said that, and she nodded in agreement.
Yeah, they upped it to 3.
Anybody get the vaccine in your group?
Yeah, I have both doses.
Good for you.
Oh, I was
The
also.
second one wasn't the most fun, but.
Well, did you have symptoms afterwards?
Yeah, I mean everything that was expected, but I was like basically in bed for the whole day after. My whole body was like super heavy. My arm hurt. I had fever and chills.
Oh, you did?
Sweating.
Wow.
I was cold. Yeah, I was like everything.
Oh.
But it only really lasted for about it started the night I got my shot, and then the next whole day. But luckily we didn't have class, so that was good. Didn't have to.
Wow. Yeah, I had just the arm was sore. And then did you join up on that the government app that was asking, trying to get responses about how you felt?
No, I didn't.
Yeah, so I took part of that, and then the questions kept on. You feel fever? I was never feverish, but right the day after I got the shot, again I was exhausted. But I'm like, I don't know if it's from the shot or the fact that the prior day I ran 8 miles and drank a bunch of beer and bourbon. I think that's more it than the shot.
Yeah, let's blame the vaccine for that.
Yeah. Damn vaccine.
Damn vaccine made me hungover.
All right, we ready? Want to get started? Monica, you good?
Yep, I'm good.
All right, here we go. Number 1, they say they tore 3 of the 4 rotator cuff muscles in the past. Which of the 5 muscles cannot be considered? What do you got?
C.
Marissa, you take that one, Marissa.
C.
C, teres major. That is correct, right? Everybody got that?
Yep.
Easy one. All right, Mel B, you got number 2.
I put A.
A, which of the following after they get a cast with the highest priority medical intervention? A. Why would you say A? What do you think's going on there?
Can't feel my fingers. Could be circulation. Probably cut off
Yes.
circulation.
Yeah, so the cast is probably too tight, whether it's the nerve or the circulation. Correct. So 2 is A. 3.
Professor D'Onofrio, just
Yeah.
going back to that question really quick. I was in between A and C. And the only reason I was because it's a home health patient. So I wasn't sure if that would be have more priority over somebody who just had a cast yesterday.
So here, so it's a good point. Both A and C, I mean, C certainly is something of concern too. A lot of times, so what happens is just to little divert a little bit here. The state board exam, when you take the exam, like say you have 200 questions, 50 questions are thrown out. Sort of like trial questions, whether they're either too easy, too complicated, whatever the reason might be. So this might be one of them that like, all right, it could go either way. It could be either A or C. For me, if I see, even for you guys, if you see something, all of a sudden they start to have skin breakdown. Yeah, that's a concern as well. I think what's more important here is the fact that, the cast, the nerve, possible swelling, and, cutting off the circulation. So that's why I think A would be a little more of the priority over C, but you can certainly justify C as being something of concern as well.
Okay.
All right. Number 3, I see. Who else we got here? Let me see. I'm losing my board here. Marissa, number 3.
I put B.
B, DVT, correct. What's the sign? What test do we want to do?
Humans or something like
Yeah,
that.
it's a Homan. Yes, correct.
Humans.
Yeah, correct. Homan sign. All right, 4. Diagnosed fibroid, which of the following tasks should be delegated to an aide? Isaiah, how about you?
I said that they should delegate to the aide on transferring the patient during the 3rd visit.
Yes. Yep, that's B.
Yeah, B.
There we go. So also with a lot of these state boards, and then you saw last year with some of her questions, and then certainly this year and definitely next year. So really for this, like the fact that the person is fibromyalgia, COPD means absolutely nothing. So when you're moving forward, when you look at these questions, really just find out, what is this question asking? So get rid of all the stuff that really has no pertinence to the question, and that's all you're really looking to answer. Because it seems like they try to confuse you, adding a lot of other filler into it. All right, number 5. Chris B.
B,
B.
standing hip abduction of the right leg.
Standing hip abduction of the right leg. Drop left leg. Most appropriate treatment of this impairment would be standing hip abduction of the right leg. Yeah, what's going on here?
He's a weak glute medius on the right side. So as he's walking, the left hip is dropping, or if he's trying to stand on one foot, the left hip is going to drop because what do they call that? Reversal muscle action. He can't keep his hips level. And,
Well, what's that called?
Trendelenburg.
Trendelenburg. Yep.
So,
Thank you.
all right. So the weakness is on, so a significant drop of the left hip while mid stance of the right leg. So you think, anybody else have a different answer?
No, I had B as
I'm a-
well.
I had B.
I'm assuming everyone said had they, you know.
B.
Everybody
Yeah.
said B.
I said B.
I
What
said
if
B.
I tell you the answer would be A?
I'd
Okay,
say I have to
so
read
is
the
it
question.
because it's
So
on
it's a
in
mid-stance,
mid stance,
right?
you're not standing on one leg?
Oh, mid stance.
And I know you guys haven't had gait yet, but we did talk about Trendelenburg and glute medius weakness. So for this scenario, let's see if you guys, I'll show you. Move my guy. So if I'm doing hip abduction, standing hip abduction to the right leg, right? Yeah, you can certainly do that. But functionally, if my right leg is weak, don't I want to put the weight on the right leg? So what does the glute med have to do if I do standing left hip abduction? Like both glute meds are working. Which one do you think is working harder? The one I'm standing on to keep the pelvis neutral, or the one that's just going,
The one
sort
you're
of
standing on.
somewhat gravity minimized?
The standing.
The one you're standing on.
Right. So functionally, so for gait, this one, A, would be actually the better exercise. Standing hip abduction of the left leg, because now the right leg, that right glute medius, has to work harder to keep the pelvis neutral. That's the Trendelenburg gait right there.
Tricky.
Yeah.
No, but that actually, gosh. I'm gonna go. I need another cup of coffee.
It's all right. That's why we're doing it. We'll get you ready. Don't you worry. We got another year and a half to get you ready.
Can I try 6?
Yeah, go ahead.
Is it C? Cubital tunnel?
No,
Oh, so then it's A.
it is a Guyon's
Okay.
canal. Yeah, so that's going to be the what nerve? I don't know if it says what nerve.
Ulnar.
Ulnar, right? So yeah, ulnar nerve. At the same time, think about where, like the distribution of the ulnar nerve on the hand and the radial nerve too.
Mm-hmm.
All right. All right, Dan. So this I know this is a newer one because you guys just had this earlier Monday. So Dan, what do you got for number 7?
I don't know. I really was just guessing because percentages and trying to figure that out with the body. I don't know. I guess B.
All right, who else? Maddie, how about you?
Sorry, that's my daughter's name. It's actually Cindy. I guess C.
What do you got? It's fine. What do you got for this?
I guess C. I'm not quite sure exactly the percentage.
C. All right. Who else? Anybody else?
D.
I have D.
Yeah. I
All
have
right.
B.
So ready? Let's do this. So
I have
actually,
C.
the answer is C. So the entire right arm. What is using the rule of 9s? What is the entire right arm?
9.
9.
That's 9. And the left arm.
9.
That's 9. So we're at 18. The front of the head. So if the entire head is 9, the front of the head is going to be what?
4.5.
4.5. So that's 22.5. And the front of the chest, how much is that?
18.
That's 18. So when we add that up, we get 40.5. C.
I just have a question there. So I thought that basically the torso was split up into like 4 quadrants, basically. So the front of the chest and basically like the upper back is 9 each, and then the abdomen and like the lower back is 9 each. So if it says the front of the chest, wouldn't that just be 9%, since it's not like the
No,
whole
it's going
front
to
of
be
the
the front of
body?
the chest. So don't go by like the specific part of the chest. Like it'll specifically say when it says front of the chest, just assume that's the entire front part of the body.
Okay.
Yeah, so that's going to be the 18.
All right.
I had a similar thought, like what might the wording be if it was referring to just the chest and not the abdominal region at all?
They're not, you would never see that. They're not going to do that to confuse you.
No.
What they would say would just be like the anterior surface of one arm, like anterior surface of the leg.
Okay.
Yeah. Or just like this, the front of the head, as opposed to, the entire head.
At the end of the day, they're not going to be like sitting there, should we bring him to the ER? Did he get the correct?
Yeah, it's yeah. But like I said, the rule of nines, but they're not gonna don't think of it like, oh geez, that's just the chest. It says nothing about the abdomen. Just assume that, and I always say we never want to assume when we're looking at these questions, but at least for like something like this, where it's just more of a calculation, they're gonna be specific, the anterior part of the arm. But yeah, when you see the chest, just assume it's all 18%. All right, 8. Jasmine, 8. What do you got?
I put D.
D is correct. What nerve is that?
Trochlear.
Yeah, nice job.
Professor.
Yes.
Because I didn't want to look up that I was trying to remember. Is cranial nerve 3, is that oculomotor?
Yes.
So what is that responsible for relative what the trochlear nerve is responsible for in terms of eye movement?
I'll give you the specific.
And then the cranial nerve 6 is the abducens. So that's
right. So, yeah, cranial nerve 6 is abducens. Compared to those. So I think. Let me see if sensory. Hold on.
Yeah, I can look too.
I got it. Just to make sure. So I guess the difference is like for cranial nerve 4, it's specific in terms of, turning the eye down and abducting the eye. So that's just more of that's more specific. Cranial nerve 4, cranial nerve 3, it's just all eye movements.
And then 6 would be just like abducting.
6 is just abducens. Yeah.
Okay. So the fact that it was specific. Okay.
Yeah.
So D. Okay.
All right. Rod Neal, how about number 9?
Oh, wait, I was gonna ask you about question number 8 really
Yeah.
quick. In regards to cranial nerve 4, so if we tell someone to look at their nose, is that using the muscles that's innervated by cranial nerve 4?
Yeah, the adductors.
Okay.
So really what you're looking to do, I don't know if you guys can see me, but what you're looking to do would be have like, a pen and just say, focus on the pen. And as the pen gets closer to the nose, you'll see the eyes adduct. All right, you want number 9 then?
Oh, yeah, my bad. I put down, I kind of forgot about this, but I put down A.
Lie the patient supine, notify the physician.
This is hypertension, right?
All right, so anybody, Juan, how about, what do you got for this one?
No, I put B.
You put B. So what's going on here? B is correct. What's going on?
Well, if you have a patient's blood pressure increase, you want to put them upright so the blood rushes down and not back up.
So what condition is happening here? And you guys had this Monday.
Orthostatic pressure.
Actually, not orthostatic hypotension or hypertension. What is this called? Anybody can jump in. Andre, anybody?
Hyper something. Hyper.
Anybody look at their notes from Monday?
Well, we're trying to
Are
think.
you
We're
guys-
not trying to
Are some
look.
of you guys like, so I walk by my son's room when he's doing online learning. He's got the class going on. He's either on his PS4 or on his phone. It's like a complete waste of time.
Is it dysreflexia?
Yeah, autonomic dysreflexia. So what we're looking at here, first off, the important things, the spinal cord injury. That's what we're looking at as, that's important because we know below a T6 or T6 and above, we have a really, we got to be careful because of that autonomic dysreflexia. Upon, symptoms would be the high blood pressure signs, the flushness, the diaphoresis, and like the headache and the heart pounding. So that's what's going on here. This is autonomic dysreflexia. What can cause autonomic dysreflexia?
Didn't you just say it? Spinal cord injury, T6 and above.
Well, that's what usually gets it. But what can cause? Not every spinal cord injury is going to have autonomic dysreflexia.
A catheter.
The catheter, right? So whether it's like a kink or blockage in a catheter, a infected toenail, wearing clothes that are too tight around the stomach, so certain things like that. Some type of, I don't want to say trauma, but something that's blocking, bowel or bladder, something like that. So that's autonomic dysreflexia with that spinal cord. So what we want to do, because the BP is 180/100, that's pretty high. We want to sit them up. So sit them up and then notify the physician. Look to see what could possibly be wrong, if the catheter or the drainage bag is blocked up, if there's a kink in the catheter, something like that.
So why would you want to sit them up as opposed to lying them down?
So if the blood pressure is high, just think of gravity helping to pull the blood out of the brain into the heart to circulate. And so that's why you would sit them up. If we work with somebody with orthotension, I don't know if I have a question coming up with the orthostatic hypotension with low blood pressure, I want to lie them down, almost like elevate the legs. And so this way gravity can pull blood back towards the heart.
Yep. Okay.
Good?
Yep.
All right. Let's see. 10. Who do we got? Steven. Steve, 10.
I am between, let me see, the Lockman's test or the valgus stress test.
Okay, yeah, I see it. Which one do you think? Which one more so than the other?
Well, it said that she got hurt in a twisting motion, so I'll
Yep.
do the valgus stress test.
Yeah, so it could be either. Actually, probably more looking at the
But then it says she can't like run or jump.
yeah, so it could be either. You're right, but more, I think, because I had changed. C was a different answer that you guys didn't know. We didn't go over. That's why I changed it. So looking here, it probably should have made it something different. So I'm going to change this right now. Let's do. All right. What's the answer now?
Let me see. Lockman's.
Yeah, A. So 10 would be A, correct.
All right.
Oh, are you guys looking at a feed that are you updating that live?
Yeah.
Oh, wait, how do my brain. Is this in the drive, guys, or where is that?
No, he's
I'm just doing it. I can resend it to when we're done.
He's doing it on Zoom.
No, I know. I'm looking at it. It's not changing them. Maybe I'm looking at, I'm looking at,
Oh, no, you know what? Yeah,
No,
you're probably on your
That's not
own.
change it
Hold
on
on.
your
Yeah, he
own.
has his own.
Yeah.
all
There's
right.
sometimes like the Commodore 3000 that you have might be a little slower. So yeah, so right, even with the valgus, yeah, that could be correct. You can certainly do the valgus again. More like first off, I would think because of the twisting motion, how do we often tear the ACL? It's the rotation and the valgus. So yeah, so let's change it to Nears. This way you guys don't get confused early on in your career. So 10 will say A. All right, 11. Brian with the Y. What's going on, Brian?
Hello. Okay. I would say a nearest test.
Yes.
Because you put the hand overhead and then so it's in that position you would test for pain, applying overpressure to
what diagnosis?
That's a good question. I would say impingement.
Yes. What tendon is impinged?
Supraspinatus tendon.
Good. What's the insertion of the supraspinatus?
The greater tubercle.
Yeah.
Okay.
Nice. See how everything all ties in?
I'm like trying to visualize it in my head.
Good.
So it's like I knew it was the top of the humerus, and I just guessed between the greater and the lesser.
Yep.
It's like I didn't know for sure, but I'm just doing like process of eliminating.
So near, yes. The shoulder impingement near, they have the painful arc, and near Hawkins County looking for shoulder impingement there.
Why would you say supraspinatus? I thought it would be bicep because it's shoulder flexion.
Well, so bicep it will assist in shoulder flexion. There is a bicipital impingement.
Okay.
But again, primarily the supraspinatus is the one mainly inflamed. And we'll get more into the the reasonings why next year, like why it's more the supraspinatus compared to the bicep, when yes, the bicep does do shoulder flexion.
Okay.
Yeah.
What's that? What's the test for the biceps again? The
Speeds test.
speeds, that's right.
Yes. Speeds test. Good.
Can you scroll back up to 10 real quick? I just want to see the change that you made. Oh, so you just eliminated valgus as that?
Yeah, so I usually, because you know what, valgus, you certainly could do the valgus test, because a lot of times, because of the medial collateral ligament becoming part of the capsule, you do see a lot of with some ACL injuries, the MCL is torn as well. So the valgus test would, you certainly would want to do that as well. So again, originally I typed this up. There's another special test there that we never did. So we'll leave it at Nears. We'll change that again. All right. So then 11, we had the Nears test. All right. 12. Andrew.
That would be B.
Right. Lateral epicondylitis. Yep. Good. 13.
I'm sorry. Sorry, really quickly. We said that 11 was what exactly?
11 is A.
Okay. All right. Sorry. Just had to double check. Thank you.
All right. 12B, lateral epicondylitis, common extensor tendons. Yes. How do we test that?
Varus force on the medial aspect of the elbow.
Well, are the ligaments involved here at all?
Nope. Not sure.
Not really. More muscular. So
No,
how do we test?
I'm not sure how to test it. I mean,
Well, if there's pain at the lateral epicondyle, if that's the common extensor tendon, the origin. So if it's muscle, how would we test this?
can you just have them do that and see if it hurts? Have them do extension movements with their wrist.
So you would have them go into wrist extension, and then what would you ask them?
Where they're feeling pain, if they're feeling pain.
So you have them go into extension, and you would ask them, all right, resist. Hold your arm here. I'm going to push down on your hand. Resist. So you're going to resist wrist extension. I'll show you when we get the video back on. All right, so let's see. Do I get everybody throughout? I couldn't have. Who did I get? Casey, did I get you?
Nope.
There you go. I know you're always the one that's like quiet in the background. Go ahead. You get 13.
Casey, quiet.
That is the first time someone has ever said that.
He's definitely not quiet.
Wow. I should have saved that.
It's being recorded.
Oh, perfect. So I believe the answer is, this is 13, so it should be C.
C, that is correct. Those are the precautions for a total hip.
Would an anterior approach, which I know you said isn't very common, but would that have just the complete opposite of everything? So instead of flexion, it's extension. Instead of medial rotation, it's lateral.
Yes.
Adduction is abduction.
Yeah.
Yeah,
but they're not so clear cut as the posterior hip. But a lot of times they would say, no lateral, no external rotation, no extension for an anterior approach. Same. Yep. All right, 14. Jasmine.
This one I put, yeah, A.
A, correct. Yep.
So just going back to that, the question we were talking about before, would C be more of an option with the patient that I forget which number it was with the spinal cord injury?
Yeah, so C would be more of the option if their blood pressure goes up. So orthostatic hypotension would be low blood pressure.
Yeah.
So C would be, if the patient also had a C6, especially a C6 level with the autonomic dysreflexia, if the blood pressure shoots up, then you would want to check the catheter for blockage.
Yeah. Okay.
So this right here would be, this patient doesn't, whether they're in bed for a really long time, which would make sense as a C6, blood pressure drops. So when you sit them up, gravity's going to pull all that blood out of their head, so they get dizzy, lightheaded. So what you would do, I don't know, did you guys have lab on Wednesday?
Yep.
Yeah, but we only really did like sterile technique a little bit.
Okay, so
This
we didn't do
past
anything with the you didn't do anything with the tilt table?
No.
Okay.
No.
So that's when they talk about reacclimate the patient to an upright position. So if the patient's supine, the patient's been lying in bed for a long period of time, it could be, it could occur within like 24 hours, say after surgery. When they're lying down, then all of a sudden you get up, the blood pressure drops, you feel lightheaded. It's no different there if you guys are on the floor picking something up and you stand up very quick, you feel lightheaded. It's the same type of concept. And so for someone like this, when we talk about reacclimate the patient to an upright position, so maybe what we would do is we go in, person supine, we do some exercises, maybe just raise the head of the bed for 10, 20 degrees, take blood pressure. Okay. Get them used to that position, do some more exercise, raise the head of the bed a little longer, take the blood pressure. So you're always taking the blood pressure to see what happens when they move upright. Again, and we're going to talk about this, which is a good tie-in then to what we're going to do later on, with this ICF, and I always say, like when you look at a baby, you need to crawl before you can walk. So let's not just say this person's a C6 because they're not going to walk. Let's say it is a total hip replacement and they wake, they get up and they're dizzy. Well, we'll talk about this again later on, but think about what I have to do. Yeah, eventually my goal is to get this person to walk, but I might not be able to get them up right away and walk. There might be some other things I have to do, prior to that. Yeah, our goal is to get you to walk, but there are steps we have to do along the way to be able to get that person to walk. And again, we'll talk about that with today's lecture. All right, that was 14. And finally, 15, Ashka.
I put C.
C7, right. Tricep reflex is C7, myotome C7. Good. All right, how'd you guys do on that?
Not bad.
Good.
A few tricky ones.
Good.
Can you go back to 14 real quick? If
yes,
not too.
I'm not sharing, but yeah, 14. Go ahead.
So orthostatic hypotension. If for example, they're sitting up and their blood pressure drops, we want to lay them back down.
Yes.
But in this case, it's already very low, even while they're supine. Right? Is that kind of what the question was? It's like low to begin.
It could be either. It could either be. It could be either way. So, they could be sitting and it could drop. And so, if they are sitting and it drops, I would then I would recline them back a little bit.
Mhm.
I don't necessarily have to bring them all the way flat, but I can recline them back. If they're already supine and the blood pressure drops, they start to experience orthostatic hypotension, what can I do then? They're already supine.
Not sure.
Anybody? If they're already supine and their blood pressure drops, what can I do?
Flip them upside down.
Flip them upside down? You mean like grab them by the legs and shake them?
Do you raise their legs?
Yeah, you raise your legs, raise the legs. So raise the foot of the bed up a little bit, get the blood to flow back. Yeah, so you're going to see a lot, like I said, reacclimate the patient to an upright position. So again, if we bring them up and the blood pressure drops, I got to bring them down a little bit. If they're already supine, I raise the leg of the bed. If the blood pressure then stabilizes, let's bring the bed up a little bit. We'll bring it up a little more. And you'll see that when we do the tilt table.
Cool.
You'll see it there. All right. So if you want to send that out again, I sent the email to everybody. So you have that, you have the answers. Little quiz of the stuff that you learned Monday, but all last semester. And really what it does is the stuff you learn, it's applying it more clinically. So those are the types of questions that you would see.
Yeah, this is great.
All right, next one. You guys good? A half hour in? All right, let's get rid of that. Save there. All right. So this is what we're going to discuss today. Let me hold on. All right. So we're going to discuss the ICF, International Classification of Functioning Disability in Health. So this sort of became a mindset of, how we look at our patients, how we're going to sort of classify to see, where they are, to get doctors, OTs, PTs, nurses, everybody's sort of on the same page of thinking, okay, how are we going to, treat our patients? How do we look at our patients? The one thing I always say when we talk about independence, if somebody is, when you think of independence, like what do you guys think of? If we're looking to get our patient back to independence, what do you think of?
They can like do normal like day-to-day activities.
Okay, so if somebody all of a sudden needs to use a walker, is that independent?
As long as they can do it by themselves, right?
Yeah, exactly. As long as they can do it by themselves. Exactly. So independence can be different. Somebody that's a spinal cord injury, independence for them might be being able for that person to teach the caregiver what they need to do. So we look at independence, we look at function, and we're really working towards function, especially nowadays because we're limited with the number of visits the insurance company gives us and changing our mindset. So they came up with this International Classification of Functioning Disability and Health System, the ICF. This then goes into, for those that have been around like a PT clinic or a doctor's office, the ICD, International Classification of Disability, which then was like the ICD-9, the ICD-10, where we're putting like numbers to the sort of the diagnosis. That's going to give us our diagnosis. That's what the insurance company is going to use to reimburse the work that you do. We're not going to concern so much about the ICD-10. It's more of like, again, the billing type of system. But you guys have seen that, yes? The ICD-10 codes?
Yeah, but we're eventually gonna need to have, extensive knowledge of that, correct?
You will. You'll get more into that, like with Professor Maley's class, when you talk about the insurance. That's not really for the mindset here. What we're going to do here. So the title, we're going to discuss the International Classification, the ICF. But what I really wanted, like when I was putting this together, my thought for today, what I really want you guys to see and to start like developing this mindset of like, how much do we want to do, or how much do we want to impact our patients? Like, what are we really doing with our patients? And so the thought of trying to teach today was, let's start opening up our minds. And I know you guys have had your volunteer hours, you've been in some clinics, and that's great. You're going to learn. We always talk about the real world and what we teach in here. Once you get your license, you guys, as long as it's legal and ethical, you do what you want to do. But what we really want to teach, which I think is going to separate us, not necessarily us as a program, but you as an individual, as a therapist, and how much impact you're going to make on your patients. So what we're going to start with, a little pre-breakout lecture. I'm going to break you guys up into a room, different rooms, and I think there's like 20. So maybe we'll break up into like 5 rooms. There's your scenario. There's your first scenario. 68-year-old man in the hospital, new diagnosis of COPD. What does COPD mean?
Chronic obstructive pulmonary.
Yep, chronic obstructive pulmonary disease. He's got a medical history of coronary artery disease, diabetes. He's a smoker. He had an MI 4 years ago, retired, lives alone in second floor apartment. Previous level activity, current level, he can get up and out of bed. He needs assistant with sit to stand. So as your little group, you're going to discuss this person. I want you to identify what you think this person's problems are and come up with a treatment. So I say, don't be specific, just broad areas to focus on. So you don't have to say, well, we're going to do straight leg raise 2x10 or bridges. No, no, no. Come up with some of the areas of treatment that you think you need to focus on. Sound good?
Yeah.
I'll jump around from room. So let me see. Participants, no. We're going to go into oh, here we go. Breakout rooms. All right. So we'll go 5 breakout rooms. All right. Go into your room, discuss this with each other, and then we'll get together, talk about it, and then we'll get into the lecture.
There we go. Throwing back that coffee.
Yeah, I'm done. I tell you, I can tell you guys. So yesterday, I learned like the right proportion, coffee, the heat. Like yesterday was the first time I was teaching class, and I was on. It was my A game. I was on fire yesterday, and I'm like, I think it's because I finally learned how to make just the best cup of coffee.
So what's the secret? Are you gonna share it?
So I use my grandmother's old fashioned, like I don't think not a percolator, like the silver ones that go on the stove.
Yeah,
Oh, a mocha
yeah.
pot.
Yeah.
A mocha pot.
It's a percolator.
Is that what it is? Whatever it is. So I use that. It was my grandmother's. It's got to be like 100 years old.
So you're making espresso over it.
That's basically what it is. That's how I make it. So, know how much coffee. So I think what I was doing in the past, I was using my one like stove, like burner, that's the hottest. So because my kid had his eggs on one, I had to move it over to the one that's not as hot.
That's great.
And it came out better. So I think I was burning it before.
Oh.
You weren't slowly warming it. You were.
That's what it was. So
it.
now I
Yeah.
slowly warm it. Oh, it's phenomenal.
So you used to go with the super dark roast.
Yes. Yeah. All right. So let's share. Get back here. So what do you guys think? This is a 68-year-old man. So it was interesting. It was some of you guys, you guys all did a good job when I was listening in, but some was like, this is perfect. This is why we're doing this. So you have a 68-year-old man, COPD from smoking, diabetes, coronary artery disease. He had a heart attack 4 years ago, second floor apartment. Prior, he was walking on his own without a device, independent, all ADLs, independent stairs. Now, with sit to stand, he might fall back, so he might need some standby assist. He's ambulating with a rolling walker 50 feet with somebody nearby. His dynamic balance is fair. He wants to go home, get to his normal life, feeling sorry for himself. He has no one to help. So what do you think? What are some of this patient's problems?
So we identified that there's definitely some sort of lower extremity weakness. Obviously, the issue with the sit to stand and ambulation when he was previously walking. But one of the things that we also addressed is possible issues with intrinsic motivation. It seems like his issues might be progressively getting worse because of his mental state.
Okay. Obviously it's written there. All right. Had somebody else jump in? So you got lower extremity weakness, and then we'll go with the psychological aspect, the motivation. Very, very common what we're going to see out there. All right, anybody else?
We talked about living situation. I think one of them is the fact that he lives on the second floor, walking up an apartment. We don't know specifically if his apartment is like cluttered with stuff, like it might prevent him from like moving around.
Okay. All right, somebody else.
Since he's having problems with balancing, so maybe there's some sort of vestibular issues as well.
All right, so you want to, okay, so balance. All right. Anybody else? What else you got out there?
You know, it's not going to be easy. He's 68 and he's got X number of years doing these things, but trying to talk to him about his diet, trying to talk to him about smoking, getting him motivated and excited to get back to where he was, giving him incentives, giving him goals, you know, baby steps, you know, talking about the psychology aspect. I mean, if you could work on his lower body strength and balance, which, you know, and these things, that's absolutely critical, but is it all going to fall to nothing as soon as he walks out of there? You know what I mean? So.
Yep. All right. Good. All right. Anything else? What any other problem
Just
areas?
kind of piggybacking off of what Chris just said, we were discussing that, you know, when you work with a patient and you're their PTA, you don't want to be their therapist, but you also want to meet them in the middle, really take time to understand what they're going through, even if it's like the slightest little bit of like motivational change, lifestyle change, just encouraging them a little bit more so that they kind of feel that there's someone there to listen to them and help them. That may help increase that motivational aspect.
All right, good. All right, let's go try one more. Anybody else? Any other patient problems that you came up with this scenario?
In our group, we've mentioned how we may want to talk to him about hobbies he may be interested in, because that could be contributing to his depression. He says he's just retired. It doesn't say that he does anything.
Yeah.
So.
All right, so you have a lot of the, so you guys address a lot of the psychological stuff. Anything else? Anything like physical system related that you might?
Well, aside from like the muscle weakness, since he has the COPD, you can look to like work on his endurance, because you're probably just gonna have like shortness of breath.
Okay, good. All right. Yeah, so you guys touched on it: weakness, endurance, balance, motivation, that type of stuff. So before we get into the ICF, and I always talked about this in some of my first lectures in the second year. What as a physical therapist, like what are we? What do we do?
We're educators.
All right, so we're educators. What else are we?
Movement specialists.
Movement specialists. Look at you reading right off the APTA website. Movement specialists. What else?
Wellness coach.
Yes, nice.
So motivators. So how about psychologists?
Yeah, to a degree,
To a certain extent, I would say.
As long as you can press like
because a person's.
All right, so let's go back. So you say to a certain extent, Ashka.
Yeah.
What do you mean by to a certain extent?
So, I mean, I'm sure we have all seen it in our experiences just at AIDS, like, and Dr. Stutz-Doyle has also mentioned it, like throughout therapy sessions, you know, you understand that patients are really kind of apprehensive. They're hesitant to tell you things in the beginning upon initial evaluation, but through working with them over therapy sessions, you start to uncover a little bit more about that patient, about their lifestyle, about how their family is, how they're interacting, anything underlying that may be going on, and they kind of start to open up with you because they trust you. So to a certain extent, like you have to be there to listen, but you're not going to be there to provide them psychological advice about how they should be doing.
Right, exactly. Yeah. Perfectly stated. You know, we do a lot of psychology type work, social work type stuff, counseling. We're not licensed psychologists, licensed social workers, but, you know, a lot of what we do is deal with fear. So giving the person the motivation to know that, hey, you're struggling now, but I know we can get to it. It's not like saying you have somebody who had a severe stroke or a spinal cord injury who you know is not going to walk again and saying, hey, we're going to get you walking. I have faith in what you can do. Yeah, we got to be realistic. But when I always, just when I think about what we do as therapists, yeah, we give exercise, but is it more of like, is the person going to get better because I gave them exercise, or are they going to get better because I gave them the confidence that if they do this exercise, if they get stronger, they're going to walk again and they're going to be able to do the things they want to do. So again, I always like discussing like, okay, yeah, we give exercise, but I think a lot of times we do more than that. Like we're the psychologist, we're the motivator, we're the life coach that, you had mentioned before. So when you talk about like the patient as a whole, and we look at, okay, what the problems are, and when we get into this ICF, like, I don't want you guys to look at the patient as, well, this is just a person with COPD. Like, oh, this is a COPD patient. No. This is a patient who has COPD. This is a patient who has a hip replacement. So one of the big things that started years ago was personalizing the care, personalizing the individual. This isn't the patient. This is a person who has some condition. And so when we keep the person involved and keep the person in our back of mind, that it doesn't matter what condition they have, this is still a person who's going through something. And so, and hopefully, we're not going to get too much more into this scenario. The last scenario, hopefully your mindset changes and we can go back and discuss some of this other stuff with this first scenario. And in one of the groups, I know one of the persons they were talking about, well, the COPD, or they can't, like, why can't they do this stuff now? There's really nothing, that's affecting them. Well, yeah, there's a lot affecting them here. So when we get into this ICF, International Classification, Function, Disability, and Health System, it's providing a common language, a framework describing the person's level of function within, and here's the key, their unique environment. So the two keys that we're discussing here are going to be function. Look at that, unction, function, and unique environment. What is about this individual person that we really have to take into account? So going back to this scenario here, this person's environment, they're in the hospital with COPD. They live in the second floor apartment. Some of you guys had talked about, well, maybe we'll discuss, maybe looking for a ranch or something else. Yeah, that is a good discussion to have with your patient. That might not be possible. And if it's not possible, what am I going to do about that? It allows the clinicians to develop a whole picture. Let's look at the entire picture, the entire story for this person, for this patient's current status, for their function. What can they do? What can't they do? What's their potential for recovery? Do I need to make some type of changes? Do I need to get other people involved to help? And so what we're doing is we're shifting the focus away from the diagnosis. This isn't a COPD case. This is a person who has COPD. How is that COPD affecting the person? How is that stroke affecting the person? How is the hip replacement, the ankle sprain affecting the person? And so that's the kind of mindset that I hope you guys start to develop over the time, and that we'll see it over the next year and a half. So proposed by the World Health Organization, 1980, it's really looking at these biopsychosocial markers to try to sort of fuse the interaction of the biological aspect of what's going on, the social aspect of what's going on, and the personal factors. So is your treatment, let's say this person here, they live on the second floor walk-up apartment. Let's say they live in, before the person was driving. and their apartment, their car was right in the back lot. So now you have a certain mindset of what I need to do for this patient. Well, now let's say this person lives downtown Newark and they take public transportation. Is your mindset different with this person depending on where they live in Newark looking to get to transportation as opposed to somebody who has to just walk in their, the back of their apartment complex to get in the car? Is your treatment going to be different?
Yes.
Yeah. So when we talk about the ICF, when we talk about this identifying, what factors are involved. So we're identifying internal, external factors, the COPD, the diabetes, the CVA, the history of MI, the psychological component, the lack of motivation. With external factors, the stairs, where they live, what they need to do. Is it, public transportation? They have to walk far. Different things like that, which may influence the person's health. And ultimately, how does it affect their performance, to their ability to perform an activity? We're looking to get this person as independent as we possibly can. So the ICF model, ultimately in the middle, we have activities. How does that health condition affect activity? And how does that activity affect the health condition? Body functioning and structures, participation, and then it comes down to other inputs, external factors, and personal factors, which we'll get into. So definitions, it's all based around the person's ability to perform an activity, to ultimately perform a function. We treat function. I have a patient with the knee replacement. They have a lot of swelling. They have limited range of motion. They have pain. Are my goals to help increase the range of motion? Well, yeah, I have to increase the range of motion, but I'm not increasing range of motion, just increase range of motion. I'm increasing range of motion so that person can be able to take stairs. I need to get 95 degrees of knee flexion for the person to take stairs. I need to increase the strength of the left leg to 3+ to 4 out of 5. So the person can increase, can take 2 flights of stairs to get their apartment. So this is going to tie into next week when we talk about doing SOAP notes and writing goals and figuring out, okay, how am I going to treat this person? It's all going to be based on function. So the activity defined as the involvement in a life situation, maintaining body positions, being able to stand, being able to sit, being able to complete higher level tasks, such as preparing a meal, dressing, swimming, whatever it may be, walking to a store, going up and down stairs. That's the activity. What does this person have to get involved and get back to? And then the health condition is that actual disease and medical disorder, and how that affects and how that plays a role in this person being able to function. So some of you guys were talking about, again, when you look at these patient problems, and I always say, I don't get into the difference between a PT and a PTA. Like, oh, well, PTs can only do evaluations, PTAs can. That's baloney. You guys assess. What's the difference between, in your minds, the difference between an evaluation and an assessment? What do you guys think it is?
The insurance company.
Indirectly, yes. So what's the difference between an evaluation and an
it's an
assessment?
evaluation, just like the general overall, like how the person, your initial interaction with that person. But then the assessment is like, okay, well, how are they responding? How do you expect like their prognosis and things like that, like what you're actually seeing?
Okay, all right. So you're putting down the evaluation as that initial meeting. So let's say the PT does the initial evaluation, and then they say, hey, I want you to see that patient. And so now this is your first time going in. Are you doing an assessment?
You have to assess whether
yeah.
the plan of care is going to be effective, and you're not going to know until you start implementing it.
So what's the difference between that initial evaluation the PT does and the initial assessment that you're doing with the patient?
Aren't you basically doing your own evaluation as a PTA just to see like where, like what you're observing in that patient, what like, based on what the therapist is doing?
I would hope you would. So basically, in my mind, the difference between an evaluation that say the PT does and the assessments that we do is putting a diagnosis to it. And that's it. So yeah, PTs, we can assign a diagnosis to that patient based on what our evaluation came up with. Different ataxic gait, muscle weakness. That's all that is. When you first see that patient, yeah, hopefully you're doing an assessment. And so the assessment that you do is no different than the initial evaluation. Because I would hope that when you guys go in and start working with your patients, you want to get your own little history. Hey, Mr. Jones, I see here, that you live in you're having a hard time breathing. Just tell me about what happened. Where do you live? What kind of stuff do you like to do? I would hope that for your own sake, you want to do that type of evaluation. So I don't look at the difference between an evaluation and assessment, because every time you walk into that patient, that you work with the patient, regardless of the setting, you are doing an assessment. So you go in, and now all of a sudden you have a spinal cord injury. You walk in, you see the patient's red, sweating. You take their blood pressure. Oh my God, it's 200 over 100. You're doing an assessment right there. What are you assessing with that patient that you go in?
Their current status.
And you're assessing that, hey, there's something going on here. This is a medical emergency. I got to do something about it. Let's say you go, let's not go that extreme. Let's say you go in and you have a patient with a total knee replacement, and you've been doing your stuff. And then they come back 2 days later, it's Friday. And you're like, hey, Mr. Jones, how are you? Oh my God, I am in so much pain. What are you doing there?
You're gonna have to modify and scale back. You're gonna have
Yes.
to.
So you're assessing what that person can do, and maybe say, you know what, maybe we did too much last time, or what'd you do at home the other day? I see this all the time. Oh, I'm in so much pain. What'd you do? You know what? I tried to walk without the cane. I didn't think I needed it, or I walked too far. So you're assessing every time you go into that patient. So yeah, we talk about evaluations the PT does. My goal is I'm going to teach you guys how to do evaluations. We'll just call them assessments. So moving on.
What did you you said there was something specific. You said evaluations lead to, what was the term you said? It was
a diagnosis, a physical therapy diagnosis.
Yeah.
And that ties into the insurance company paying for what we're doing.
Right.
So other definitions: body functions, the status of the physiological function of the body systems, including psychological functions. So psychomotor control, visual spatial, visual perception, vestibular, cardiovascular, respiratory, muscles, the joints, flexibility, strength, mobility, perception of pain. So when I go back and I look at that COPD place, do I really need to know that something else is going on, that there's some other diagnosis? Not really. I know that because of the COPD, his endurance is limited because he has a hard time breathing. Because of that, his cardiovascular system might be shot because of the COPD. So we'll discuss this, but older people after they're 70, when they fall and break their hip, they have a greater risk of dying. You guys aware of that?
Can you repeat what you just said? Because
if you look at stats, an older person, and obviously the older they get, the greater risk they are. But a patient that's over 70, if they fall, they break their hip, they get surgery, whatever, they have a greater risk. They're at a greater risk of dying, increased mortality rate with somebody over 70 that falls and breaks their hip. So my question is, does breaking your hip lead to death?
No,
No. What does it do though?
massive depression when you can't do anything that you're used to being
It
able to.
weakens.
Increases
It
the
already weak
risk.
to begin with, so your healing process isn't as strong as somebody who.
Okay.
were-
What else happens?
Well, it decreases your capacity to do much. I mean, from a functional standpoint, from an exercise standpoint.
Okay, what happens because of that?
Well, there can be internal bleeding, necrosis.
So that's
some
all
sort
taken care
infection.
of. There's no bleeding, that's fine.
Well, so I mean, you're not in a good
Joseph
position
independence.
to exercise, so that could advance certain diseases you have. If you have heart disease, you have diabetes, and you can't necessarily exercise to help counteract that, they're gonna progress faster.
You're afraid
Right.
to fall again.
What's that?
You're afraid to fall again.
You're afraid to fall. So when you're afraid to fall, what don't you do?
Stop
Not
walking.
You stop moving. So a hip fracture, a fall involving a hip fracture doesn't kill you. That's not why you die. The hip fracture, the fall leads to a fear of falling. I'm afraid to fall. I'm not going to move as much. Because I don't move as much, my cardiopulmonary, cardiovascular, respiratory system, immunological system, everything decreases. So because I'm not active, everything just snowballs. So a hip fracture doesn't cause death, but everything else that happens because of me not moving, getting weaker, everything breaking down a lot quicker, that's what's going to cause me my untimely death. And so when we talk about body functions, when you're looking at your patients, you are looking at everything involved. I know one of the groups, they talked about balance, which is great. They talked about the vestibular function. We'll get more into that next year. But yeah, that's something that I need to address. How about, what are some other things with older people that happens? Hey, you guys see me now? Wearing these stupid glasses?
Yeah, their eyesight decreases.
Your
too.
eyesight decreases, your hearing decreases. Is that going to affect how you, this patient? So yeah, we got to look into that. So when we talk about body functions, we got to look at everything, all the systems. When we talk about then body structures, status of anatomical parts of the body, organs, limbs, their components, how does that affect what we have going on? The brain, the spinal cord, nerve gets slower, conduction gets slower as we age. The heart, is it strong enough? Is it working like it should to send blood throughout and oxygen to go to the muscles? So the muscles use the oxygen as energy to be able to pump, work harder, stronger, longer. Respiratory system, are we getting enough breathing? Is enough oxygen coming in? Integumentary system, the skin, is it healing properly? Is there an ulcer on the bottom of the foot that causes this person not to walk? And so now they're not walking. Are they going to get worse from there? Are the bones strong enough? Does somebody have osteoporosis, joints and ligaments? So that's what we're going to assess. We're going to look at all of that. Range of motion, strength. Yeah, that's what we do. But we're doing it looking at the entire body. So 2 types of additional contextual factors, your environmental, external environmental, your physical environment. So they're looking at the availability of food, drugs, products, technology for personal use. Can this person get out and go food shopping? Can this person go out and be able to get their drugs? Do they have money to buy their drugs? Stuff like that. Social attitudes, legal, social barriers, different stigmas. Funniest story, I had a lady who was 90 years old. She fell. Luckily, nothing happened. I go in and I'm like, listen, I really think we should start working at least with the cane. She's like, I'm not using a cane because that's only old people use the cane. So in her mind, she still thought herself as young, but the vanity, she didn't want to use a cane because the stigma associated with a cane could lead to her falling again. And it was, again, a battle where she did not want to use that cane because of what people felt. So you're going to deal with that as well. Architectural, look at the building, the design, steps. You guys haven't done it yet. Hopefully we'll do it this semester. This building is the worst when it comes to ADA compliance. Doors are too heavy, getting in and out of the bathroom, elevator. So those are other factors that we have to deal with. That scenario, that person lives on the second floor. Is he going to be able to get up and down the stairs so he can, survive again? Assistive devices, can they get them? Where a wheelchair, walker, prosthetics, orthotics. And then financial assets. I know a lot of times you guys have talked about the insurance and the costs. Can they pay for it? Is the insurance company willing to cover certain things? And then other factors, the internal personal factors, age, gender, social background, education level, different experience, support staff, different behaviors. So you go back to this guy here, well, you know what? The fact that he feels sorry for himself, that can really affect everything else that we do here. I can come up with the best treatment ever, but if that guy doesn't have the motivation to do it, it doesn't mean anything. So I always say to my patients, you have to have, the responsibility is yours. Like, I'm not going to get you better. You're going to get yourself better. I'm going to give you the means to which you can get better. But unless you take responsibility yourself, it's not going to matter. So again, I go into numbers of like, I come see you 3 days a week. I'm here for an hour. There's 23 hours during the rest of the day and days where I don't come at all. That if you think because I showed up 3 times a week, you're getting better, that is not the case. And so that's part of the motivation, part of the psychologist that we have to provide, the psychology we provide to get this person motivated to be able, for them to do what we want to do. And so when we get into discussing goals, well, let's make the goals appropriate and let's make them similar to work for. And it goes back to before we can walk, we got to crawl. Before we can run, we have to walk. And so take that mindset. So now when we go back to this person here, so before they can walk, if they have difficulty standing for a long time, what do you think we can do with this patient?
If they have difficulty standing for long periods of time,
Yeah.
Have them stand.
Exactly. Yeah. Have them stand for a long period of time before they can walk and take a step. What are some activities we can do?
Marching.
Oh, go ahead. Sorry.
No, that's good.
Yeah, Ash,
Like
what were you
marching in
saying?
place.
Yeah. So how about weight shifting? How about marching in place with the walker in the parallel bars? So hopefully you guys start to see and break things down of like baby steps. Well, I know in order to get this person to walk, I need to get them to be able to stand for a longer period of time. I need to be able to get them to weight shift. I need to be able to be able to lift the legs up. So you want to look at breaking these activities down and setting up smaller goals with the ultimate goal of like, okay, he's going to walk 300 feet so he can get to the bus stop, stuff like that.
Going back to that patient that you had, the 90-year-old,
yeah,
who didn't want to use the cane. I actually like that. I like that she didn't want to use the cane. I mean, it might have been a little frustrating, but the fact that she didn't want to use it to me is like, she's in the game. She doesn't want to rely on that.
No, and I totally agree. And so if that's the case, what would you say to this patient? We'll get somebody else. Monica, you have a 90-year-old patient who doesn't want to use a cane. What can you do?
We could switch over to the parallel bars, and I would want to show them how they can walk without a cane, but to convince them to leave the clinic with a cane, I tell them it'd be a short-term goal.
Perfect. Yes. So right on. Listen, you know what? Let's start with the cane now because of the weakness in your hip. I don't want another fall. If you have another fall, who knows what could happen.
Yep.
And so that's what you want to say. Short term, I think it's important to use the cane. Our goal is to get rid of it. And so there, you're giving the person motivation for them to want to be able to walk without the cane. I'm going to do all the exercise that you tell me to do because I want to get rid of the cane. Perfect. All right. So here's the change. Now this is what we're going to start to think. So the ICF example, we have our health condition. It's a spinal cord injury from MVA. That results in the impairment, which would be paralysis. That causes difficulty with activity limitation. So now they have the inability to get downstairs to access public transportation. That'll lead to participation restriction, unable to get to work, unable to get to friend's house. And so now all of a sudden that leads to other problems. So when we go back to that first scenario with the COPD, health condition, let's say it's COPD, resulting in some of your impairments, weakness, balance, let's just say loss of endurance. So COPD resulted in diminished endurance, causing limitation of him to take the stairs to get out of his house, of him to be able to walk 100 feet to get to the bus stop, of him being able to go into the supermarket, walk up and down the aisles to be able to do food shopping, of him to be able to go see friends. And so that's the kind of the mindset that you need to take using this ICF example. Yeah, you're not going to have to specifically, jot down the ICF when you're out in your clinic, but I want you guys to start to really think, what is this? What is the diagnosis that I'm given here? What is it really causing? I'm not treating a total knee replacement. I'm treating somebody who cannot work or cannot walk or go up and down stairs because of the knee replacement, causing weakness, pain, limited endurance, which is then causing problems with the stairs or now using a walker. So you see how our treatments are going to be a little different now. Our mindset is going to be different using an example like this instead of just treating a diagnosis.
Totally.
So our summary, by using this format from this previous slide, use that as the example, we can then determine interventions to address problems associated with each of those domains. We are coming up with a treatment plan that is going to address that patient, our individual patient. If the patient only has 3 steps in which they need to go up, am I going to focus on going up and down 2 flights of stairs? I'm going to worry about just him getting up and down 3 steps. How about this? What am I going to work on? Let's say we go back to this patient here, back up to this patient. Let's say they live downtown Newark and they have to cross. You guys ever walk around Newark on your when the weather was nice?
A little.
Yeah.
Okay. Let's say they have to cross Market Street. They want to go to Dinosaur Barbecue.
Well, good choice. Good choice.
All right. And they got to go across Market Street. You guys ever cross that street?
Yes, no.
It's a death trap.
It's a death
A
trap.
lot.
So what are other aspects of gait? And you guys didn't do gait yet, but think about it. What do I got to make sure that this patient can do?
Able to go up and down the curbs and stuff.
So they have to go up and down curbs. That's one. What else?
Be able to
on one leg.
street without people bumping into them and all that.
Okay. So they need to navigate the street with other people going in and out. What else they need to do?
You have to do it quick enough. So
They have to do it quick enough. So when this person first comes in and I'm starting to see this person the first day, if I spend, let's say I spend he's there for an hour. I spend a good 20 minutes just having a conversation with this person, getting a really thorough background. Hey, tell me all about your living condition. Do you have to cross the street? What do you do? So now I know that this person here has to go down one step. They have to cross Market Broad, which is crowded, and they have to get there at a certain time because people aren't waiting. And so I don't want this person all of a sudden to come back because they got hit by a car.
It's like Frogger. They got to.
So now is my treatment going to be different for this person compared to somebody that lives out in the suburbs?
For sure.
Yeah, absolutely, for sure. So now let's say they're in the rehab center and we're getting them walking. And they walk 1,000 feet in the hallway with the cane. And then they're getting ready to discharge. Do you feel good about yourself?
They're not ready.
No,
Why not?
because that's not a real life scenario. You're not going to be walking on a level surface outside in a hallway with nobody around you.
Excellent. Great. Yeah, absolutely. So this patient here, they're in the rehab center where you're working. And wow, this great job. This person, you got them walking 1,000 feet. Unfortunately, the insurance company doesn't like that. But anyway, that's great. Well, but you know what? They walked on a controlled surface that was well lit, that's flat, that's wide. Let's get them to the cafeteria. Let's have them walk when other people are coming in and out of the rooms. Let's have them maneuver around furniture, around equipment. Hey, you know what? It's a nice day. Let's go outside. Let's go walk on the grass. What do you think happens when somebody walks on the grass or a different surface?
A lot less stable.
A lot less stable. So that's what you have to think about. What is this person? What do I need this person to get back to? What am I going to gear my treatments so when that person leaves the home, I give them the best opportunity for them to survive? Walk on different surfaces. Let's go up and down one curb. Let's go on an uneven parking lot. We talk about, again, the body systems, proprioception. We need to regain proprioception. Somebody that's in a cast, and then all of a sudden they take the cast off or they're non-weight bearing. Don't you think the bottom of the foot, the sensory innervations are different now than when they were walking? So now we need to add different sensations, different feels to that person so they can get that sensory feedback back up to the brain to re-educate it that, hey, I've been walking for a month on a flat surface. I don't know what it's like to walk on macadam, on a street, on grass. So I need to train them to be able to do that as well. So getting back to summary. So that's what we really want to do. So the idea of this scenario, of this lecture here, it wasn't to, teach you the ICF, but it was more to start to develop that mindset of understanding our patients. What do I really need to get this person back to? How much motivation do I have? Do I have to give them? What am I going to set up? What is my treatment going to be that I know is going to work towards that goal, that specific goal that I set? You guys understand that? You see that different mindset?
Yep.
Yeah.
So one more scenario. I'm going to little breakout section. So now I'll give you like 10 minutes. Think of what we just covered, what we just discussed. And then think about the entire body, every system involved. and how that could affect what we do. Sound good?
Yeah.
All right, so let me stop sharing. We'll come back here. Breakout rooms, recreate. All right, so I'll send you guys into the breakout rooms. I don't know if they're going to be the same or different. We'll see. Like I said, 10 minutes, discuss it. Think of it if you had any changes, what your mindset would be now after we talked.
Sprinkles. Yeah, there's not a lot left, Maddie.
All right, we're almost done. All right, so I don't know if you guys saw this scenario any different after my spectacular lecture.
You did knock it out of the park, I must say.
I like to listen to myself talk. So, all right, so just so after this, did you look at it any differently? And I know going through each of the different groups, I didn't really include a lot of like a history here, a social history, what the person was doing before, where they lived, stuff like that, which again, I think that's very important that you guys, when you do finalize a treatment plan, that's what you would need to know. So like this wasn't necessarily, hey, come up with specific treatments. We have plenty of time to do that. At the same time, that this mindset, what you read from the book, when we talk next semester, and even what we've done, last semester and finish up this year, when we talk about scenarios and you have, your hip replacement, and what can we do with the hip replacement? And, what are the precautions? Well, not every scenario is just clear cut where it's, textbook, hip replacement, this is what you have to do. Most of our population is going to be like this guy. Hip replacement, might have diabetes, COPD, develops heart arrhythmia. Well, those aren't from the book. So what I always say, and you're probably not going to remember it, but when we start the Therex component, the first lecture, I talk about think outside the box. Don't let anybody tell you that what you might do with your patient is wrong if you can justify the reason behind you doing it. Years ago, somebody started doing boxing with Parkinson's patients. Why would you box with a Parkinson's patient? What do you think?
Well, going tons of control. Oh, go ahead, Casey.
No, go ahead, Chris.
No, just saying, they're showing tons of control and, coordination by doing that,
So we know with Parkinson's, you have that fascinating gait, right? They walk pretty much like, robotic. What do you do with boxing?
A lot of balance, a lot of weight shifting.
A lot of balance, a lot of weight shifting, a lot of trunk rotation. What else? Somebody with Parkinson's, they don't walk as much. What's going on cardiovascularly?
Well, decreased cardiovascular.
Decreased cardiovascular. You think maybe some boxing can help increase that cardiovascular endurance?
Oh, definitely.
How about it being fun? Don't we want to make our treatments fun for our patients? I know for me, I get bored. I get such, my ADD, forget it. I get bored. I like to be creative. Try to make something fun for me as well as for the patient. Let's keep them motivated. So going back to that first guy, we talk about how he feels sorry for himself. Let's see what he had done. Let's say he's a fisherman. What can you do?
Play some sort of games with him where he's, simulating fishing.
Yeah. Let's pretend, hey, you know what we're going to do here? I want you to stand, stagger your feet a little bit. Pretend you got a fishing pole in your hand. And I want you to throw it out. Well, what is he doing? He's working on balance. He's working on trunk control. That's going to help. What do I have to do to get this person to walk? I need trunk rotation. I need balance. I need stability. Hey, let's go outside. I'm going to bring my fishing pole in. Let's go outside and throw. So those are things that you can use with the motivation. Let me find out, what does this guy really like to do? What did he do in the past? Well, I just like to play chess. How can I make checkers or chess harder for this patient?
Yeah, I mean, if they're bored out of their mind and they're not engaged, that's when they're going to start canceling appointments or, not showing up or whatever, or just showing up and going through the motions. It's like,
Right. So let's take that chess scenario. And somebody else, give me some ideas. So instead of him, he's been sitting all day, but he loves chess. So what can I do instead of having him sit and do chess?
He could do chess boxing.
He can do chess boxing. He can throw the chess pieces at you. Somebody else. Jade, what do you got? Give me some ideas.
I would borrow a giant chess set and make it more of a gross motor thing. And
that was kind of what I was gonna.
Yeah, you could something like that. You can do different. Have him stand while he's doing it.
Mm-hmm.
Maybe have the chess table to the left, and he has to turn to the left. Maybe have a couple chess things set up, and he has to rotate. So the whole point is, don't get stuck in the mindset of, okay, I'm treating a knee replacement. No. You're treating the person who just happens to have a knee replacement. And so all other aspects. So I don't need to get into the specifics because again, next year, we're going to do a lot of this. I don't need to get into the specifics of, okay, what do I have to do with this person specifically? I need to get my goals. What does this person have to be able to do to get them happy, to get them functioning? And then I'll come up with my specific treatments. And then I'll change my treatments each time as we go along. And we're going to make it fun, right? What do we want to do with our patients?
Make it fun.
Make it fun. So
I've got a question about that. Because I love this line of thinking, but in terms of, for example, documentation, that dreaded thing, you're having them play games, you're having them do different things, and it's really, you're able to justify it, but can you put in there you're having them play chess or whatever? And
all right, so let's say it's not just that he's playing chess
or whatever. Yeah, that was just the example.
Standing at a table, working on trunk rotation to the left, to the right for 5 minutes. So I'm working on standing endurance. I'm working on static and dynamic balance. I'm working on trunk rotation. I'm working on core strength. I'm working on weight shifting. I'm working on spatial. I'm working on crossing midline. So just because I call it chess, I'm not going to play chess for 10 minutes because the insurance company ain't paying for that. But standing at a table with the chessboard, having patient reach over, certain things like that. One of the games that people love, and you see it, is going to be balloon volleyball. Are they hitting a balloon back and forth? Well, yeah, but they're working on seated balance. They're working on dynamic control. They're working on visual spatial relationship. They're working on shoulder flexion, shoulder strengthening, trunk rotation. So that's how you're going to document it. You're not going to document that I hit a balloon back and forth. I pretended to throw a fishing rod. No, I brought that up before. So for those guys that have to leave, don't worry about it. I'm pretty much done anyway. Again, I can talk forever. So you understand that, Chris, that's how we're going to do it.
Right.
And so when I say, think outside the box, don't let anybody tell you that it's not a good exercise. Because if the patient can do it, if you can justify the reason behind doing it, then it's a good one. I can't tell you how many times I would come up with I would think was a creative exercise only to do it and it sucked. And I would be the first one to say, you know what? That exercise sucked. Let's do something different. And so what's most important is your patient safe. You're justifying your rationale as to why I want to do this. But if your patient's safe, that's all that matters.
Right, yeah, and then you trial and error, and you come back next time and you retinker, you retool.
Right, don't be afraid to fail. As long as my patient's safe, don't be afraid to fail. That's it.
And if you come up with a really good exercises, your coworkers will steal it.
If you do, right. up stealing it. So that was the idea behind today. Yeah, we use the ICF as the model, but I really want you guys to come out of this and thinking more, be more creative, think more, globally about how this person's condition is going to affect them and what I need to do to get that person back to doing their function. And that's what I'll tell you this great story. So I had a patient who had stage 4 stomach cancer, and we knew it wasn't going to be a lot of time. His goal was strictly, I want to be able to walk my daughter down the aisle at her wedding. And we worked for like a few months, building up strength to the point where one of my treatments, we went to the actual church and we walked up and down the aisle the distance. He did better. I brought the daughter over, we played music, and I had them dance together. He actually made it to the wedding, and he said it was like the greatest thing. I went, people came up to me to thank me just so they can see the guy and the daughter dance.
Perfect.
Oh my
And that's it. And so, yeah, it was,
Great.
anybody could have done it. It wasn't me, but it was more of like, okay, what do I need to get this patient to do? So that was the idea for today. So again, hopefully you guys, pick up on some stuff. You're going to get better as you get experience. Be sponges. Talk to other therapists that are out there. When you start going on your clinicals in a few weeks, talk to other therapists. I'll talk to you more about some things that you can do to help yourself. Come back with questions and also question what they're doing. Not to question like that sucks, but hey, why are you doing that exercise? Why, what else can you do? Take advantage of your clinicals. There's no such thing as a bad clinical. All right. Any questions here, guys?
No, this was great. Thank you so much.
Thank you for the lecture.
Thank you. Thank you.
Yeah, thanks.
All right. Enjoy the rest of the
Thank you.
weekend. We'll see you next week.
Thanks, Professor.
Thank you.
Also, Professor, before
Yeah.
we go, definitely look up chess boxing. It's an actual thing. I'm not even kidding. It's an actual sport.
Chess boxing. All right. Maybe we'll bring it in here.
All right,
gotta
sounds
keep
good.
away from the big, if we do chess boxing, I don't mind it, except I'm not going with the big buck. I'm afraid.
Hey, listen.
I want Casey in the first round.
All right, let's go. Let's go. Have a good one.
All right, guys. Thank you.
All right,
Professor.
guys. Have a
Thank
good
you.
weekend. All right. We'll see you next week.
You too.
Okay.